Our next presenter will be Dr. Peter DeMaria, who is the coordinator of psychiatric services of the Tuttleman Counseling Center and clinical professor of psychiatry and behavioral sciences at Temple University School of Medicine. Dr. DeMaria will speak on psychiatry and co-occurring disorders.
So many of the people in the room, I think, are clinical people who have worked with patients. And so I'd like to present two vignettes that I think will help bring us into the same, we'll be able to understand what we're doing. Okay, I'm clicking the button, but it's not working. Okay, so first vignette, we're in the medication-assisted treatment program, and the counselor is talking to the patient, and the counselor says, "How many pills are you taking?" The patient then responds, nodding off in the chair, "Only one at bedtime as prescribed." Dr. McNicholas, I think, has been here before. The counselor says to the patient, "Does your doctor know you're on the program?" And the patient responds back, "Yeah, I guess. I think we talked about it." Okay, translated, no. Let's cut to the next scene. Now we're in the psychiatrist's office, different patient, and the patient is saying to the psychiatrist, "I'm really having a lot of anxiety and panic attacks, and I can't sleep at night." The psychiatrist then says to the patient, who's nodding off in the chair, "You look tired now." That was a Rogerian reflective comment. The psychiatrist only has 10 minutes with the patient. I thought that was pretty generous. Okay, so the patient responds back to the psychiatrist, "Yeah, I'm really not sleeping. Isn't there anything you can give me?" And the psychiatrist responds back, "Here's a prescription for clonazepam and zolpidem. I think they'll help you. If you don't prefer those, maybe alprazolam and temazepam," listening to some of the previous things. So I thought about what's going to be most helpful to hone down on the issues with regard to psychiatry, and I came up with 5 axioms. The first one is that addiction is an anxiety-provoking disease. And I think many of us would recognize that for people who are actively using, there's the whole issue of where am I going to get my drugs? Where am I going to get the money to get the drugs? How am I going to manage to get it? And then there's the intoxication, then there's the withdrawal. What do I tell my family? And that doesn't stop when people get into recovery, because once they get into recovery and they start working on these issues, they realize a lot of the bridges that they've burnt and a lot of the problems. And so how am I going to get money to feed my family? How am I going to find a job? I've got to meet with the parole officer, etc. So we need to acknowledge that the mere process of having an active addiction, and even early in recovery, is an anxiety-provoking experience. We also need to recognize that the comorbidity of anxiety disorders and psychiatric disorders in general is very high in our population. Therefore, we need to make sure that we ask about these symptoms. We need to be aware that they're high comorbidity. I think Ken Minkoff says that co-occurring disorders are the rule, not the exception. So as a psychiatrist, I concur, obviously. We need to screen for these symptoms, and we need to include them in our treatment plan. If we do that, then we will have a better chance. If we're aware of what we're trying to deal with, we'll be able to do that. Axiom 2 is communication is essential. I realize this makes perfect sense, but again, if you look at some of the vignettes that I presented, to what extent does the right hand know what the left hand is doing? So our addiction professionals need to be in touch with the mental health professionals. Mental health professionals need to be in touch with the addiction professionals. Unfortunately, the history of treatment for mental disorders has frequently been split. Actually, it's typically a three-way split: alcohol, mental health, and drug addiction. The reality is, as a psychiatrist, they're all in one book, the DSM. Many people have problems with that book, but that's the book we're using. And so hopefully we can pull this together. Ideally, in our programs, we would have services available, including mental health services, psychiatric services. I always felt lucky in many ways when I was involved with methadone treatment as the medical director. As a psychiatrist, obviously, I felt very comfortable in being able to address psychiatric issues in my patients. I understand that in other settings, depending on the personnel at the program, that may or may not work as well. But there needs to be communication back and forth, as the two vignettes hopefully pointed out. Axiom 3, if you don't ask, you won't know. And the corollary of this axiom is, even if you do ask, you may need to ask again and again and again and again. So part following up with what some of my colleagues have said, when patients are visiting with providers and they've already screened, first of all, they need to screen for, if they're meeting with a mental health provider, I always wonder whether or not the mental health provider asked about their use of drugs or alcohol, ask whether they've had treatment. My experience in general is that if you ask people in a non-judgmental way, they'll tell you, and then you can then be able to make good decisions. If you don't ask, you're not going to know. Likewise, in the addiction facility, you need to ask about mental health and find out what's going on in that realm. So this type of communication is really critical, and being able to ask about these symptoms and ask about it, because then you'll be able to make better decisions. Axiom 4, this some people may have some arguments about, but after having spent most of my clinical work in trying to get people off of benzodiazepines, I feel pretty strongly about this for patients who are in medication-assisted treatment. And that is that patients who have taken benzos for longer than 7 years will probably never get off them. Now, that's a fairly strong statement, and I'm certainly willing to try and back it up with some of the data. But I think one of the most critical things here is that it depends where we as treatment providers set the goal. If the goal is the person needs to be abstinent and they can't achieve that abstinence, they will live their life feeling like a failure. Now, for those of you who have worked with patients in medication-assisted treatment, you realize that they come to us frequently with many, many failures in their life. Many times by the time they come to us, their family has written them off as being failures. They've incorporated that they're failures. Many, many people have suggested it. We as providers need to meet with them and understand them on an individual basis, as one of the questionnaires pointed out, to be able to set up what are reasonable goals for the patient. Many people, if we don't do that, then they continue to live with that feeling that they're a failure. So for those patients who have been on benzos for a long time, we need to make an informed decision about how to manage these patients' benzos and realize how difficult it can be to taper off of them. And interesting, as I was preparing this, I was going through and I found this little slide here, which I thought was kind of cute, and the person saying, this pill is not addictive, I should know. I've taken it every night for the last 20 years. So I think Mark Twain also said that quitting smoking's easy. I've done it thousands of times or hundreds of times. And axiom 5 is that not all benzo use is abuse or dependence. And so I encourage us to be sophisticated as we approach this topic and realize what others have also said, and that is that for some people, these medicines are very helpful and are important and necessary medicines. The importance for us, though, is to go in with our eyes open and be aware that they also carry with them significant addictive potential and the potential to create a lot of problems in our patients' lives. If you look at the research on benzodiazepines, the vast majority of prescriptions for benzodiazepines are not abused, the dose is not escalated, and many times people don't even use all that they are prescribed. So they're highly effective in the treatment of anxiety disorders, but alternatives do exist, and I think later on we're going to hear about some of those. When evaluating patients, a careful decision-making process is necessary. And I think this is the one piece that's very important for us to be aware of and to incorporate into our clinical practice. It may not be as the person using benzos or not, but for people who are using benzos, what is the role? What's their relationship with these drugs? And to what extent are they helping or hurting? When is what are the patient's diagnoses? What are the alternatives? What alternatives have been tried for the patient? What is the patient's recovery plan? Are they working a plan? Are they involved in counseling or therapy? Are they following it? And do the benefits outweigh the risks? So ultimately, that's a decision. The key is it's a process. And I think, as Dr. McNicholas said, a practice I frequently did is that you meet the patient, you start working with them, and then you start trying different things because there isn't a good body of research to tell us. And finally, I leave you with some other little tidbits that might ring true for you. Anyway, I thought about making the T-shirt and selling it to raise money, but I thought that might be a little too risque. Anyway, thank you very much.